Hi, so my name is Linda Zhang. I'm one of the Advanced Therapeutic Fellows at Johns Hopkins, and we'll be demonstrating an EMR case today, and I have with me Dr. Andrew Gatt.
Yes, Andy Gatt. I work at Kaiser in Orange County. I'm also an advanced endoscopist as well.
Okay, so for the purpose of this demonstration, we don't actually have a lesion, but we're going to pretend that we have an imaginary lesion here in front of us. The reason we picked this area is because it's in the 6 o'clock position, and when we try to do any kind of polypectomy or EMR, we always try to rotate the scope so that the lesion is in the 6 o'clock position. It's the most ideal for where our equipment comes out of the scope. So what we're going to do, the first step of EMR is to obviously inspect your lesion, make sure that you can see all of the borders very clearly, make sure that there's no evidence of deep submucosal invasion before you proceed. So we're imagining we have a benign looking lesion here, and what we want to do next is to do a submucosal injection. So we have the needle in at the moment, and I'm going to ask my very experienced assistant to put the needle out. And what we try to do is we try not to inject into the lesion itself. You can definitely inject into the lesion if it's a very benign lesion. You can go right into the center and it can save you some time. But it's good to try to inject outside of the lesion itself. So this is a pig's stomach here, so it's a little bit harder to get into the space. Normally I would actually be more gentle, and I would kind of come up to it, I would ask my assistant to start injecting, and then I would advance and start to pull back until I see the submucosal lift, which we're starting to see here. And it's a dynamic injection that we're doing, so as he's injecting, I'm also pulling back and maybe adjusting the angle of my catheter as well to see which way my lesion is going to come up towards me. So the other thing you could do is also ask your assistant to just let you know how much they're injecting. Because if they've injected like 5 mils and you're not seeing anything coming out, then you're probably in the wrong space. Okay. So we're getting a bit of a lift here. And it's actually going really well, so I'm just continuing in this space for now, but we can stop there and needle back. Okay. All right, so now that we've got a good lift here, we can go to our snare. And the choice of snare that you'll use will depend on the size of the lesion. This one's not very big, so we're going for a 15 millimeter snare. Dr. Siddiqui had mentioned in her talk earlier today, you probably don't want to do a snare that's bigger than 20 millimeters because that'll increase your risk of perforation. So again, we want to keep the lesion at the 6 o'clock position. We want to open our snare above the lesion and making sure that the snare is open nicely so that the tip of the circle is just coming up at the catheter and you're not seeing that straight bit of the snare. And then you want to tip down and get some force on some downward pressure on the lesion. And you want to start to apply a bit of suction. And you want to apply a downward force as you start to ask your assistant to close the snare. So slowly closing, and I'm applying the downward force. It is slipping a little here, so I'm going to try to open, try to desufflate my lumen a little bit more. And we'll try to do this again, but let's see how this goes. So we're suctioning and keeping a downward force. So I can hold both my scope and the equipment at the same time by using my left pinky. And I can lock my wheels in position to make it more stable. And I'm suctioning and I'm asking my assistant to close at the same time. Keep closing, keep closing, keep closing. Okay.
Nice job.
And so we could potentially cut all the way through cold here, and we're trying not to do that. We want to take this one hot. We've made that decision. So we're just going to close until we're tight, and he's going to give me feedback that he's tight there. And then we're going to slowly cut through. So my foot's on the pedal here. We've got our polypectomy settings there, and then I'm cutting through using endocut, and my assistant is closing it at the same time.
Beautiful.
That was...
Yes,
Okay.
perfect.
No, good.
So Once we've removed it, we want to inspect, and we see a nice blue defect here, which is good. We can see the submucosa. So we know that we're good, we're safe, and we don't have any evidence of deep injury. We could also try to demonstrate cauterize the edges. Yeah. So I guess if we remove the lesion en bloc, then we're probably pretty good if we've taken a wide margin and we can see that it's all normal tissue around us. If we were doing piecemeal EMR, then we would want to take the next piece right next to the margin of this defect here and making sure we don't leave a little bridge in the middle. And then we can also, as mentioned in the lectures this morning, we can also use the snare tip to just go around the margin of the lesion and to decrease the risk of recurrence. So we'll just get a little bit of snare tip.
Linda, I think Dr. Krinsky had a question for you.
Oh, I just was wondering if there's any other tips when you used a nice suctioning to grab the whole polyp, entire polyp.
Yeah.
Any other tricks if it continues to slip?
Yep, so my next step, if that didn't work, was to try to do underwater EMR, so suctioning all of the air out of the lumen and then filling the lumen with water. That helps the mucosa to kind of float up and it reduces the space there, so that would be my next step. And then something else would be band EMR as well, creating a pseudo polyp before we remove it.
And also the snare itself, they also have different design, like a drop snare and other device that should actually be stiffer, and you can also grab, the mucosa margin easier. So the snare itself also action for this.
Yeah. So the next thing we'll do is snare tip. So we'll imagine that we have some snare tip soft coagulation settings there, and we just have a little bit, just a few millimeters of the snare tip out, and using the blue pedal, soft coagulation, we're just going around the margin of the defect.
Sometimes I have a challenge just orienting the snare tip, especially if you have a polyp in a difficult position, just getting it just right. Any suggestions on that?
Like getting the right orientation?
Yeah, getting the angle, especially if your polyp to begin with was in a difficult position.
Yeah, absolutely, especially for the bigger lesions, right? The ones that go like over the fold so I think so the way that I do it is just to do what I can see in front of me, and then to try to change the orientation. So whether that's by suctioning or rotating my scope to try to get, I just do the visible areas, but also keeping in mind like the areas that I haven't hit to make sure that I do get everywhere.
And also an experienced assistant is also very important. The
Yeah.
person who also can help Dr. Yang holding the scope and torque in certain direction, as you know.
That's a great point, Dr.
Yeah. So I think that having an experienced tech who work with you that can also hold a scope in a certain torque position for you certainly allows you to do some of those difficult lesions as well.
Yeah. So I think, so what you want to see when you've done snare tip is a margin of ablated tissue, so just like we're seeing there. And
we were planning to make it even more perfect, right?
Yeah.
With the Purostat.
Yeah. So, in patients who are at high risk of bleeding, if they're on anticoagulation, or if this is a big defect, and especially if you're sending the patient home, which we do for most of our patients, we want to close the lesion, and there's a few options for closure. Obviously we have clips, but there is also this Purostat gel. So this is a hemostatic gel, and it forms a matrix, and it activates actually on contact with blood. So because this is a pig's stomach, it won't activate in this model here, but you'll be able to see what the gel looks like. And the idea is that you have a syringe of it on a catheter, and you want to slowly just go over the entire defect, and you want to coat it with this gel. So the way that I usually do this is I start from distal and then I move towards proximal. The reason being, if I start proximal and then I move distal, it does set pretty quickly, but I feel like I'm kind of pushing it off where I've already positioned it. So I always go from distal, and then I just work systematically. And then you just work with your assistant. You want to kind of do a blob at a time. So could you just give me a little blob there? So I think we
This
might
is not
have.
blood, so it might not actually.
We might have. Is that Puristat there, or do we
Yeah,
prime with
yeah.
water? It is Puristat, yeah. So because this isn't blood, it's not coming out kind of in the jelly-like format. But what we would do is just start from distal, slowly move. I'm moving 1 millimeter at a time, and he's just injecting a little bit at a time.
Yeah, it doesn't
Yeah.
form a gel.
So it's not forming a gel here, but what you would see normally is you would actually see a layer of jelly-like tissue over the defect. And the idea is that that jelly would form an adherent matrix, and it would last for, I think, at least 3 days. And that would prevent delayed bleeding and delayed leaks, and it would assist with healing.
And if our participants can go to the virtual exhibit hall, we actually have some links to and see how the device works when the blood is there. And now we're going to show.
Oh, we're also going to clip. Okay. So we have this is a resolution clip. So the benefit of this clip is that there is one-to-one rotation for the endoscopist, so I can rotate it however I like here.
I can also do it for you. Different.
Yeah, and it can also be done by the assistant. So open. So I think here it's a relatively linear defect, and you can probably close it with one clip. But if we were going to do multiple, we would do distal to proximal, so angling down, making sure we have both sides. And you can actually look at it and you can wash it and look before you deploy. So it looks like we've got both sides, so we can deploy there. And then your assistant will open it, and then. Okay, so we could do maybe one more clip. I'm also suctioning the lumen to try to deflate, which will help me to bring the tissue together. So open. So again, I'm rotating it a little. I am angling down, making sure I have both sides of the defect, and giving some downward force, and suctioning a little as we close. And we can inspect and make sure we got both sides, and we can deploy. And it looks,
beautiful.
Inspect our lesion, and it looks like we've been able to close it completely.
That's textbook, perfectly remarked.
Thank you. Thank you.